Namaste Vidya, Hamisha Kushal Vidya. A very good morning to you all. Myself, Julian Dr. Ravi Chen, Assistant Professor, Department of Practice of Medicine at Jyoti Vidyapith Women's University, Chennai. In today's lecture, we will be discussing about gastric carcinoma. Gastric carcinoma is the leading cause of cancer deaths worldwide. It is a more common chronic atrophic gastritis with intestinal metaplasia and dysplasia. Let me recall the series. We are discussing the chapter of alimentary tract disorders. Uh, in the last few lectures, we have discussed about peptic ulcer diseases. We have also discussed about Zedi syndrome and NUD in the last lecture. And this is the continuation of that series in which we are going to discuss about gastric carcinoma. So, gastric carcinoma is the leading cause of cancer deaths worldwide. It is more common chronic atrophic gastritis with intestinal metaplasia and dysplasia. So metaplasia and dysplasia you have studied in pathology in second year. So there is no need to revise these things. The intestinal carcinomas are more common and arise against a background of chronic mucosal injury. So these are very common and they arise against a background of chronic. So there is a chronic mucosal injury and due to which the intestinal carcinoma arises. The world 50% of gastric cancers develop in the antrum. So 50% of the gastric cancers they develop in the antrum. 20 to 30% occurs in the gastric body and often on the crater curve, and 20% are found in the cardiac. Macroscopically, the tumors may be classified as polypoid tumors, ulcerating, fungating, or diffuse. So they may be classified as polypoid, ulcerating, fungating, and diffuse kind of tumors. Bodman has classified the gastric carcinomas into 5 types. The number one is polypoid and fungating type, as you can see the figure. The second one is ulcerating lesions with elevated borders, see the figure. The third one is ulcerations with invasion of the wall. The fourth one is diffuse infiltrations, that is known as limitus plastica. And the fifth one is one that cannot be classified on the basis of these 4 classifications. So I will repeat once again. Type 1 polypoid and fungating. Type 2 is ulcerated lesions with elevated borders. Type 3 is ulcerations with invasions of the wall. Type 4 is diffuse infiltrations, limitus plastica, and type 5 that cannot be classified. Now, what are the different risk factors that can lead to the development of gastric carcinomas? Number one is H. pylori infection. So the first one is H. pylori infection. The next one is smoking. The third one is alcohol. So these are the factors that predisposes or the people who are taking these things or H. pylori if present in any individual that can predispose to or that can lead to the development of gastric carcinoma. The other factors include dietary association with salted or smoked meat, the autoimmune gastritis, the adenomatous gastric polyp, the previous partial gastrectomy, the hereditary diffuse gastric cancer families, and the familial adenomatous polyposis. The clinical features. In the clinical features, earlier gastric cancer is usually asymptomatic. So in the earlier stage of gastric cancer, it is usually asymptomatic. It is discovered during the endoscopy for investigation of dyspepsia. So if a patient is coming to you, old age patient is coming to you with the complaints of dyspepsia and you have undergone endoscopy for a patient, then gastric carcinoma is detected accidentally. 2/3 of the patients with advanced cancers have weight loss and 50% have ulcer-like pain. So 75% of the patients have progressive weight loss because in all the cancers we have weight loss. And 50% have ulcer-like pains. There is anorexia and nausea that occurs in 1/3 of the patients. The early satiety, hematomasis, melena, and dyspepsia alone are less common features. So anorexia and nausea occurs in 1/3 of the patient. We have seen weight loss, we have seen ulcer-like pain, anorexia, nausea. And early satiety means very patient जैसे खाने बैठता है जल्दी से पेट भर जाता है, easy satiety like very long. Hematomasis, melena, and dyspepsia alone are less common features. These terms we have already discussed in the previous lectures. So dysphagia occurs in the tumor of the gastric cardia, which obstruct the gastroesophageal junction. The anemia from the occult bleeding can occur. What is the pathophysiology? Pathophysiology that is involved in the cases of gastric carcinoma. All the tumors are adenocarcinoma that are arising from the mucosecreting cells in base of gastric crypts. Most develop in the background of chronic atrophic gastritis with intestinal metaplasia and dysplasias. The carcinoma can either be intestinal or diffuse from normal gastric cells. The intestinal carcinoma are more. So the pathophysiology involves all the tumors are arising from the mucosecreting cells in the base of gastric crypts, most develop in the background of chronic atrophic gastritis with intestinal metaplasias and dysplasias. The carcinoma can either be intestinal or diffuse from normal gastric cells. The intestinal carcinoma are more common. The jaundice or ascites may signify metastatic spread. So if a patient is coming to you with jaundice or ascites, so it can signify that the patient is having metastatic growth in case of gastric carcinoma. Now there are some important signs that we have to remember in case of gastric carcinoma. There is Troisius sign. Troisius sign is related to any abdominal malignancy that has left supraclavicular lymphnode enlargement. So that will suggest of abdominal malignancies. That is Troisius sign. Tumor spread occurs to the supraclavicular lymph node. There is another sign that is called as Sister Mary Joseph nodule. The umbilicus, the discoloration of the umbilicus is seen. We will be seeing this in the next slide. There is Buchenberg tumor. This is seen in the cases of ovaries. The metastasis occur most commonly in the liver. So metastasis can occur in the liver, lungs, peritoneum, and bone marrow. These are the sites. These are the most common sites at which the metastasis usually occurs. Okay. So this is Sister Mary Joseph nodule. You can see the discoloration of the umbilicus. Now investigations. What are the various investigations that we can do in case of gastric carcinomas? So the first and the most important investigation is the upper gastrointestinal endoscopy. So endoscopy has to be done. Multiple biopsies from the edge and base of the gastric ulcer are required. So multiple biopsies have to be done. Along with endoscopy, the biopsies usually performed. The barium meal is your alternative approach for the diagnosis of gastric carcinoma, and CT scan shows evidence of intra-abdominal spread or liver metastasis. Now, how will you manage the case of gastric carcinoma? So, surgery, because if it is spread, then chemotherapy and all can be done. But surgery is advised with the resection offers the only hope for cure. The radical and total gastrectomy with lymphadenectomy is usually performed. There can be esophagectomy, and Billroth 1 works and why reconstruction is usually performed. These you have already studied in your surgery class last year, so I won't be going into detail of things. You can refer your surgery books for more details. Now, palliative treatment. This comes with the chemotherapy. The first one was the surgery, and the next one is the chemotherapy. This palliative treatment, because we cannot cure the patient, but we can give that patient a palliation. Chemotherapy using FAM, that is FAM is 5-fluorouracil, doxorubicin, and mitomycin C or ECF. There is endoscopic laser ablation for control of dysphagia or recurrent bleeding. There is endoscopic dilatation, laser therapy, or insertion of expendable metallic stent for relief of dysphagia or vomiting. Now the prognosis. The prognosis of gastric carcinoma is very poor because it is usually seen in the old age individuals. Less than 30% surviving less than 5 years. So the prognosis is very much poor. So this was all about gastric carcinoma. We have discussed the etiopathogenesis, the clinical features, investigation, and management. In the next lecture, we will be talking about the celiac disease. That is also another very important disease that we have to study. So this session was powered by Digital Version 2.0, Jyoti Vidyapeeth Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box. I'll try to solve. So this was all for today. Thank you very much. We will be meeting in the next lecture with celiac disease.